And what was, it was what is called in the United States utilization review. We try to compare, now we say benchmarking, between hospital, between the different departments of the hospital, by the different type of patient, what has been done, what has been spent. But that, you see, at this time, in the United States of America, was really an innovation. And he has worked at least 10 years until having a state-level experiment in the state of New Jersey, just west of New York, where the governor decided to implement, to generalize for all the hospitals of the New Jersey, the DRG system. Okay? So that is the first phase, and they were doing, we say, benchmarking between hospitals, between physicians, within each hospital. Okay? But that was just an initiative of one state of the United States. Then, yes. So utilization review, multi-dimensional product of care, and the idea of Robert Fetter was this will support equity between the different type of funding and efficiency. His idea was we have to distinguish when a patient is coming in an hospital for a coronary surgery, okay, or for a flu. You see, it's not the same thing. So it is equitable to give more money for one than for the other. But on the other hand, by doing benchmarking, we can show that for the same type of patient, some hospital, some physician, for some type of patient, for some type of hospital, some are performing better than others. And of course, it will be better that the one performing less well, in terms of cost, for instance, try to do the good job where other people were doing, okay? So that is the first phase. And on this picture, you can see on the left, the Professor Fetter, I think it was in 85, and on the right, a young man. I have some difficulty to recognize, but that was me 42 years ago. Unfortunately, I didn't stay like this. The second, that was the step one. So it was rather clear, you see. That was, they said, and so always for this first time, begin to understand what is until then seem unexplainable, what is up, the rather strange cost behavior of hospital, okay? And I developed this point for the United States, for that was the first place, but in fact, the situation was the same in all the country, was later on have decided to introduce DRG. There was really no difference. The second point, until this time, this step one, the saga is simple, okay? Then arrive a second step, the so-called PPS, prospective payment system, decided by the Medicare administration, the Federal Administration for Financing, in 1982. And this decision is related to a name, to a man who later on won the Nobel Prize in economics. This man is named Milton Friedman. And he was the head, creator of the so-called School of Chicago, who was more or less, you see, a modern presentation of what is called liberal economics and marketing as the main motor of the economics. And you see this school, when I have met some people in the States at that time, in France, in Europe, we're still using the word free market. And the assistant told me, why free market? The market is free by definition. There is no free. You cannot say that the market is not free. The market is free. You see? The market is only value you can find. Anyway, so he convinced Reagan administration at that time to use the DRG, done initially for utilization review and benchmarking. It convinced to use that to pay the hospital, on a way prospective payment system for, as I have explained at that time, Medicare was paying whatever was done a posteriori, after. You see, the hospital was sending the bill and Medicare was paying, okay? Whatever was the bill. So they say, no, that cannot work like that. It will be prospective, meaning that each year we will give a price for each DRG. At that time, there was 500 groups, okay, 500 price. And the hospital will send as a bill the DRG of the stay, okay, and we will pay this fixed price, which of prospective price setting, meaning that the risk was transferred from the payer to the hospital. That means if the hospital is treating this type of patient, this DRG, for less than the price, it earns the money, okay? On the opposite, if it is not able, or is treating the same patient for another a supplementary price, it takes the risk. So can be more or less bankrupted. And so that is, you see, a second point, and which is very often confused with the first one. And it is, on the other hand, it is the way US hospitals are still paid today. Okay? So, I started formally in '83, was complete in 4 years. That means since 30 years, the US hospitals are paid on this basis. Okay? And I will be back in another presentation on the effect of this system. Okay? But one thing at least must be said, that there is still hospital in the United States. So they don't kill this, it doesn't kill the system. But you see, these two contradictions were noticeable. And what was important is that at that time, from our story in France, is that at that time, when the decision of the prospective payment system was taken in Washington, D.C., we were working in France to import the system working in New Jersey. Okay? Not the decision of Milton Friedman. So that was the second step. But the two first steps are more or less in the United States. The third step was a very curious phenomena, kind of epidemic, I would say, to use a medical term, the globalization of the tool, I call, with the localization of the use. That means that at that time, France was leader. We say this information system is quite good. Compared to what we have, or I will say we have not before, we don't know what it is, we don't know what we are doing, we cannot evaluate, we cannot do anything. So compared to this, it is a good system. But we don't wish to use that in the Milton-Friedman way, Reagan-Milton-Friedman way, for the competition between hospitals. For us, it was just the same time, you see. Some people that predict it will be awful for the hospital, it will be too sudden, and so on. And so we say that will be used for management and planning. And this epidemic start in Europe, then spread to Australia, which is not the same part of the globe, and then progressively went all over the world, okay? In Asia, in Africa, in Japan, anyway. So it was a little bit funny, and very often people against the introduction of the information of the hospital information system were just arguing against the prospective payment system, which is two different things. Of course, it's clear that you can use this information system for funding as a PPS. That's possible, but it is not the same thing. And so, as you can see on this slide, and the slide will be at least put on the site of Dr. Prakash, of the Institute of Dr. Prakash, just to say, you see, it is a kind of family, and all these different type of DRG have relation. They look like. You see, this is the Canadian one, this is the French one, and this is initial, the Yale DRG, which became the ICFA DRG, Healthcare Financing Administration, which now is named CMMS, anyway, and you can consult it regularly on the site of the financing administration of the federal government, with a lot of modification, lot of things. But the next step was another surprise, is that all this country, starting by importing the US information system, saying, no, we will not use as in the US, but we are going to copy the information system, say, finally, it's not exactly what we need as information system, and what I called the localization of the tool. We need to develop our own so-called grouper, which is the software you need to produce DRG groups, okay? And, but they were always saying, but we keep on management, planning, epidemiology, not for prospective payment system, okay? And what is impressive, and that is a list of the following, you see. The first one is the US, then you have the Nordic country in Europe, which have their own, France as its own, Hungary as its own, the Australian, they start with a national, who went to, was used in Australia, in Singapore, in Thailand. Then the company 3M developed the all-patient DRG, initially in the United States, mainly to the fact that the ICFA DRG was used only for patients over 65. And so it was not very developed for children, for instance, okay? And pregnancy and things like that. So they have developed this so-called all-patient. Then they refine the all-patient refine DRG, which introduce level of severity, meaning, in fact, that was just the kind of output from the success. At the beginning, even in the United States, where in the 70s was nearly the only place we can find data, coded data on diagnosis and procedure for all the states, there were very few secondary diagnoses. So a principal and maybe one secondary diagnosis. And then it increased considerably the number. And when the number of secondary diagnostic increased, the quality increased, it was possible to do distinction between level of severity. No severity, 1, 2, 3 level of severity. Higher DRG, but you see the list is boring. Thank you. Austria, UK, Canada, Japan, the Netherlands, Germany, Turkey. In Malaysia, the United Nations University has developed one, and Korea